All right, so I'm going to be doing my presentation on diastolic left heart failure. Um, so heart failure is mostly associated with the impaired left ventricular systolic function, but about 30 to 40% of all patients with heart failure symptoms have a normal or slightly low ejection fraction. And in these patients, diastolic dysfunction is a major contributor, if not the primary cause of heart failure. Heart failure with normal left ventricular systolic function without cardiac valvular lesions is typically considered diastolic heart failure. Um, Primary diastolic dysfunction is typically seen in patients with hypertension or restrictive cardiomyopathy, but can also happen in a variety of other disorders. What was interesting to me was in an article that I read was that even though diastolic heart failure is common in clinical practice worldwide, its existence has been questionable. It's been questioned whether these patients truly have heart failure or if they actually have conditions like obesity or pulmonary disease that can mimic heart failure. And in one of the studies, they actually did an echo and concluded that most patients with suspected heart failure and preserved systolic function were inappropriately labeled as having diastolic heart failure. And they had other factors, including like lung disease, that were causing those symptoms. Also, even though some may agree with that some patients with heart failure do have normal ejection fraction, they doubt that the problem is truly left ventricular diastolic dysfunction. Some of these patients have small abnormalities of systolic function. In some cases, the relations between left ventricular pressure and volume on a cardiac cath don't make a classical pattern of a typical diastolic dysfunction. So really diagnosis and treatment of diastolic heart failure has really lagged behind systolic heart failure, mainly due to the issues that I just kind of pointed out. As far as the pathophysiology behind it, um, it's really characterized by low cardiac output that results typically from a ventricle that has thick walls but a small cavity. When the left ventricle is stiff, it relaxes slowly in early diastole and has a lot more resistance when filling in late diastole. So the diastolic pressures are higher. The low cardiac output signifies fatigue, and the higher end diastolic pressure is transmitted backwards through the valve, which is what causes someone to have dyspnea, shortness of breath, and so on and so forth. These abnormalities are what trigger the neurohormonal activation in systolic heart failure. Symptoms may be revealed during physical activity because, unlike normal patients with diastolic heart failure are unable to adjust their stroke volume by increasing their left ventricular and diastolic volume. And these patients have exaggerated systolic blood pressure response to exercise. And the mechanisms that make up abnormal left ventricular diastolic properties are stiff, large arteries, hypertension, myocardial ischemia, diabetes, and intrinsic myocardial changes. As far as sort of like a sign, or I guess, yeah, symptoms and signs, you would have dyspnea, fatigue, exercise intolerance, and signs would be JVD, pulmonary rales, peripheral edema, and radiographic imaging would show us pulmonary vascular redistribution. Trying to think what else there would be. There would probably also be interstitial edema and pleural effusions as well. History, now in history, physical exam and chest X-rays aren't really specific enough to differentiate the heart failures. So using clinical evidence to diagnose is pretty questionable, actually. Yeah. So now, for as far as coexistence of the systolic and diastolic dysfunction, most patients with heart failure have abnormalities in both systolic and diastolic function, and there are big differences between them. Patients with heart failure and preserved ejection fraction may have a small but detectable abnormality in systolic function, and patients with diastolic heart failure commonly have a normal left ventricular volume, higher left ventricular mass, higher wall thickness, and lower volume to mass ratio, and higher chamber and myocardial stiffness. Now, Now, as far as diagnosis of diastolic heart failure, there needs to be three conditions: showing signs and symptoms of heart failure, obviously, showing normal or slightly reduced left ventricular ejection fraction, and showing an increased diastolic pressure and impaired filling caused by delay, isovolemic relaxation, or elevated stiffness. In patients with shortness of breath on exertion, pulmonary arousal, gallop, sound, but with near normal systolic function are usually diagnosed with diastolic heart failure. As far as non-invasive assessment of diastolic function, the most common methods used are 2D and Doppler echocardiography and Doppler tissue imaging and radionuclide ventriculography, and MR myocardial tagging and MR imaging. For invasive, there'd be cardiac cath with simultaneous pressure and volume measurements is typically our gold standard for assessing left ventricular diastolic function. Now for the management of all of this, according to the guidelines from the European Society of Hypertension and the Joint National Committee on Prevention, Detection, Evaluation, Treatment of High Blood Pressure, there actually really isn't a specific recommendations for its management. So there are no definitive guidelines for treating diastolic dysfunction, although I would say there are about 4 treatment goals for the therapy of diastolic dysfunction. Want to be reduction of central blood volume. You can use diuretics for that. Improvement of left ventricular relaxation. You can use calcium channel blockers or ACE inhibitors. Regression of left ventricular hypertrophy. By reducing the wall thickness and removal of excess collagen by ACE inhibitors or ARBs. And then there's maintenance of atrial contraction and control of heart rate, which can be helped with beta blockers and antiarrhythmics. And that's pretty much it. And here are all my references that I got all this information from. Thanks for listening.